Welcome to the first webinar of our six-part telehealth webinar series for fiscal year 2021. Today we're going to talk about telehealth services in the Rural Hospital Emergency Department, or TeleED, as you'll hear it referred to a lot. And our speakers today are Dr. Kelly Roan of Val eCare and Dr. Richard Summers of the University of Mississippi Medical Center, Department of Emergency Medicine.
Nicole, thank you for inviting me, and thanks to everyone who is on the webinar today for coming to learn a little bit more about teleemergency care and how they can be used in rural settings. And I want to apologize for my voice. I'm just getting kind of over a little bit of a cold, so apologize for that if I'm a little scratchy. I want to talk a little bit today about the background, just e-care, but also teleemergency care and rural health care and how teleemergency works. And it can work in a lot of different ways. So I'm going to kind of probably bring this from the way that we do it and the way that I do it. But also I want you to kind of open your mind to different ways that you can use technology to care for very sick patients across the miles, and then what impact it has. And then Dr. Summers will talk after me, and then I think hopefully we'll have some time for questions and answers after that. So a little bit of background in why we started doing this and why there's such a passion for doing tele-emergency work is because of the challenges that happen in rural healthcare. And I understand that completely that I am preaching to the choir here with this group, but we know that 120 hospitals have closed in the past 10 years in rural areas, and 31 states have seen at least one rural hospital shut down. And the hospital, particularly in rural areas, is such a big driver of the economics in a rural community. Usually the hospital and the school are among the largest employers in the area. And so when that shuts down, it really is very difficult for those communities to continue going on. And we know that 49% of community hospitals reported an operating margin of less than 2%. So the margins are very low here. And we also have a challenge in our workforce. Over the last 10 years, ED visits are up 24.7%. And boy, in the last 3 months, they've been up in our area exponentially. So, you know, we're continuing to work in challenging times with more and more patients that we're seeing in our EDs. And 20% of our patients live and work in rural communities. So we want to make sure that we have the workforce in order to care for them. And the average time that people spend waiting in an ED before seeing a physician or an advanced practice provider is 24 minutes. And shortages exist in staffing. So those are some of the things that we're going to be talking about. And the other thing is 96% of medical professionals think that burnout is an issue, and that's a pre-COVID number. 65% believe it's a serious problem. So not only do we need to support those patients that are being seen in rural emergency departments, but we really need to support the providers, the nurses, everybody that works in healthcare in these rural areas as well. So how do we use virtual health in order to kind of move that forward? And telemedicine has been known to improve access to care, improve access to specialists, to increase the number of people that are working on a specific patient or a specific problem in healthcare. And we want to improve care and outcomes, as well as lower costs to the community and to the healthcare community in general. And then also improve our workforce sustainability. And so we've been doing that since 1993 and want to kind of help other people to really understand how teleemergency can be used to help patients in their own communities as well. So like I said, we've been doing telehealth since 1993. We started with some teleconsults, and we started our teleemergency program in 2009 with help from a nice grant from the Helmsley Charitable Trust. And I tell you that because, you know, we really went into this as a way to help the rural communities around the area that we live. I work in a tertiary level 2 trauma center, and we were taking calls from the rural hospitals around us. And we knew that, you know, we were hearing things over the phone, but getting that visual would be so much more helpful. And so really piloted it here in South Dakota, and where I live and work, and then found that it was really helpful. We were getting great outcomes, as well as having our partners really feel like it was helpful to them. And so we're able to grow that beyond our borders. And from there, that has really, in talking to our rural partners, helped us to look at other areas that would be helpful to rural areas. And I'm not going to cover all of those, but of course, behavioral health, e-hospitalist, ICU, and then all of the things that we did during COVID to support rural hospitals as well. So in our entire footprint, we have 600 sites, and that's throughout all of our service lines. But what I want you to know is that we really serve 17% of all critical access hospitals in the nation. It's really a mission to look at critical access hospitals and rural hospitals, and look at the challenges and try to find ways to help them. And again, I know that all of you on this call look at challenges in rural areas every single day and are stepping up to the plate to figure out how we can help them in new and better ways. So I took this picture when I was in West Texas visiting one of our sites, and it's just, I love it because as I drove by, I was like, stop the car, I need a picture of this. Our town is so small, we had to borrow a horse to make a one-horse town. So this is McCamey, Texas, and it's a great little hospital in West Texas, but this is actually right outside their town. And I think just kind of tells us how rural health is, but it's a place, I think, when you work in a rural community in healthcare, you're not only you know, caring for those in communities, but you're caring for your friends, your neighbors, your family members. And so that brings a lot of wonderful connections, but it also is challenging to take care of people that you know, especially when they have really difficult medical problems. So I wanted to show you kind of our footprint in our emergency space. And you can see we started in South Dakota, so kind of that growth was organic around us, and then through the Midwest. And then a little bit on the East Coast there too. We work with Dartmouth with their TeleEmergency program and help them to run that as well. So we're in 14 states and 210 hospitals. And I think, you know, healthcare is healthcare no matter where you are. But each critical access hospital is very unique in what they can offer and how far they are from tertiary care. And there's even some regional differences. You know, I always tell, if I have anybody on here from the great state of Texas, you guys have snakes that certainly cannot survive up here in South Dakota. So I've had to do some learning of some different regional things in order to help with those emergency cases. So it's always interesting in emergency care for sure. But I think that map really correlates with this map, and this is the map of emergency density by population in our country, by county. And you can see that we really have a shortage of emergency physicians in much of our rural areas, particularly in the middle of our country. But also you can see in all areas, including the South and the West, and our mountain states. And so how can we use connectivity to really augment the care that is being done in those areas, but also help to recruit and retain people to work and live in rural areas, which I think is, you know, a really good possibility, particularly as connectivity increases in all of these areas. So let's talk a little bit about how teleemergency works. I think a lot of people think of teleemergency as telestroke or telebehavioral health. And it is that, it absolutely is. And those are wonderful programs. We see those same patients as well in the emergency department. But I want you to kind of think that it could be so much more, and it could be so much broader. And so this is a couple pictures from our hub and then from one of our hospitals that we work with. And so that's me with one of my nurses on the top, and I'm at one of our stations. And so each station has a monitor and a camera so they can see me, as well as I have a computer, my nurse has a computer, and a phone so I can help to make phone calls. But you can see that I'm driving the remote control, and my nurse and I kind of fight over that remote control, but we move the camera from our side on the patient side because we want to make sure that the staff on the patient side doesn't have to move the camera or change it. They can really be hands-on, and that camera should just kind of go into the background. And I think that's true for any telemedicine service that you're looking at. I think the connectivity, while it may be complex in the background, it should be very simple in the front ground so that the staff that are using it, it's easy for us to troubleshoot it, and it's easy for us to use it and be able to hear and see the things that we need. And then, so that station, I have about 15 of those stations. So if you think of it as an emergency department, the patient is on this camera, but I, as the emergency physician, can move from camera to camera. So I may be seeing a patient in Montana on one camera and then move to a different one and be seeing a patient in New Hampshire. So the nurse stays with that camera just like they would in a room of a patient, and they can be documenting and helping the nursing staff in that room, but I can be moving from place to place. And then on that bottom picture, you can see that I'm able to talk to the staff and they can see me if they need to, but I can see everything in that room. And in fact, I can see an EKG if they put it up on the back wall. I can use my 20x zoom lens and see it just as clear as if it was right in front of me. And then the microphone is a 360-degree mic right above the patient's feet. We do that pretty specifically because there's a lot of noise up by the patient's head, including suction and oxygen and things like that. So it helps me to be able to hear everything in the room, but also if the staff there are busy putting in IVs or doing an airway, their hands are free and they can talk to me and let me know what I can assist them with. And you can see on the wall there's a little red box, and I'll give you a little bit better picture here of that. That box is how you would turn on the service. And so, I think all teleemergency services are a little bit different, but the way that we set ours up is that it is a direct line into the emergency department. So we don't use Wi-Fi, we use fiber. And the reason why we use fiber is we want it to be 100% there all the time. You actually have to kind of cut the line with a backhoe or something for it to not be up and ready to go. Because we know that, when someone's not breathing or if they're having a seizure, all I need you to do is to push that one button on there, and that's going to ring into us and we'll be able to help you. So I don't want it to be confusing or difficult, and the bedside team has time to hit that button if someone comes in, just like a code button, but we don't want them to have to kind of go get a cart and set it up and log in and all of that stuff, because really what they need to be doing is paying attention to that patient. We don't have a magic acuity, so they can call us on anything. We see a lot of the big, bad, and ugly, of course, is what they call us for, but they decide which patients that we help them out with. And then I just wanted to show you a couple of other things that if you're technology based or clinically based, I think are kind of fun to think about and look at. But when we started doing teleemergency, the single most scary thing that we do over the camera is an airway. And so most people have heard of intubation now. That's how we put a tube down someone's airway in order to help breathe for them, either with a bag device or with a vent. And we use these, what's called a laryngoscope, and they have video laryngoscopes. And so King Vision and GlideScope are just some brands that people use. I'm not saying one in particular. We use, lots of people use lots of different kinds, but these are two very popular ones. But what they do have is a port on the side of them. And so when they are looking at that camera and seeing what they're looking at in the airway, I actually have that up on my 32-inch screen. So I'm able to see the airway and kind of guide their hand if that's a difficult airway, because we know that it's so important to be able to oxygenate those patients. And we see, like I said, all sorts of things. Certainly the number one thing that we see are cardiac and chest pain, but also we have a whole team that does behavioral health. And that was something that we started kind of later on as we were talking to our partners, and as we collaborated, they said, boy, you know, what's really difficult is getting patients an assessment and placement from a rural area. We see a lot of trauma and neurologic issues, including stroke. But you can see all the way down to OBGYN. And I have now helped deliver more babies over the camera than I have in real life in 20 years of emergency medicine. So we also know that there are maternity deserts in our country. And so having someone there for you when you're delivering your very first ever baby that you've delivered is helpful. I had a PA that was delivering a baby in a rural area, and she was getting ready to deliver the baby, and she turned around and looked at the screen and she said, "You're not leaving me, right?" And I said, "I'm not leaving you." So just having that little bit of someone behind you to tell you exactly what to do. And then cardiac arrest, I should mention we run at least 3 codes in our department every single day. Some days more, some days less, but being there and helping with the sickest of the sick, and not only helping them if we get that pulse back, but helping them when that pulse is not coming back. And sometimes kind of talking through when is the right time to be done with that code, which is a really difficult decision, particularly if that's someone that you know. I was working on Saturday night, and I have a couple of calls from Saturday night that stick with me, and so I'll share them. But one of the people in the room, when the patient came in, she said, "That's my dad." And I mean, you guys know in rural areas, you are taking care of your family members and your friends, and that's really difficult. And so being able to be that person that's kind of one step back and helping them to continue to work and support that person in the room is really important. So we do have 24/7 access. ERs open all the time, nights, weekends, and holidays too. Like I said, behavioral health assessments is a huge piece. And then we can also initiate diagnostic testing if the provider on site is either busy with another patient, or in many of our rural areas, they're on call from home. So while they're coming in, I can actually be there to help with, them to get things started. Again, on Saturday night, I was helping a small hospital that was about 90 minutes from a tertiary care center. And about midnight, a 50-year-old gentleman came in with chest pain, and they hit the button for me to look at the EKG. And it was very clearly, it was a inferior lateral STEMI, so a heart attack. And I was able to talk to the patient, tell them that they were having a heart attack, but I was also able to have my nurse call for a helicopter so that we could get that going, start the patient on medications, get them to get that x-ray in. And I also talked to the cardiologist, got them an accepting provider at the heart hospital that was, again, 90 miles away, and was able to tell the the nurse practitioner when she got there what was going on, and that I'd already talked to the cardiologist, and they had recommended us giving TNKs, which is a clot busting medication, and was able to go through kind of the risks and benefits and make sure that that patient was an appropriate patient for that. So if we had waited that 20 to 30 minutes for the nurse practitioner to come in from home, that patient would have had 20 to 30 minutes more time having their heart attack that wasn't being treated. So there are some definite use cases where time is really important. And then we do leverage, we can be the backup for an APP staffing model in some of our very rural areas. They may not be able to staff a physician on all the time, or they may only have 1 or 2 physicians in their county. And so giving them a little bit of a break for work-life balance is really important to keep them in that community and keep them taking care of patients there in their rural areas. So we do over 200 sites currently. And again, we did a couple of studies that showed that we are available about 17 to 21 minutes sooner than the local physician in rural areas, either because they're with another patient or because they're coming from home. And over 90% of the clinicians that we work with believe that having teleemergency helped with recruitment and retention. So what's the impact of teleemergency care? These are just kind of showing you some of the numbers of encounters that we do every day. And the green on the bottom is video encounters. The brown is behavioral health. And then we also do phone consults. So sometimes people just have maybe a medication question or something like that. And then we also keep track of patients that maybe would have transferred out to a larger facility, but we help them to be able to manage that patient locally. We're never going to try to keep patients there that really do need a higher level of care. But for most of you who work with rural hospitals, you probably know that it's harder and harder to find a bed these days, and sometimes impossible. And so we are managing these patients that are sicker for longer periods of time in rural communities prior to being able to get a bed in an ICU or a higher level of care. This is that same number of our clinicians who thought that this helped with recruitment and retention, but also with nurses. We know there's a nursing shortage as well. We support the nurses as well as the providers, and it's so important. I mean, I think if you are a new nurse or even a seasoned nurse, but you think about that new nurse working night shift in an emergency department, and your provider is at home, and something big and scary comes in, and you have a button to push to have someone there for you until someone else comes to help is a really big deal. And the other thing that we do is, if a patient is ever violent, we will always stay on, and we can help to call for backup, police, etc., because we know that emergency departments can be dangerous places to work. And if you are far from the other RN in the middle of the night, you can hit the button and we can at least help you by calling for extra help for you. So this is a case study that we did with a hospital here in South Dakota, is Wagner Community Hospital. And they were really having a difficult time keeping workforce, particularly provider workforce. And so they did take a couple of their nurses and they were able to send them to either PA school or nurse practitioner school. But then adding both a teleemergency program as well as telehospitalist, they were able to increase their patient satisfaction score on the inpatient side from 24% to 99%, just having someone there who lived and worked in the community and had that kind of desire to work with those patients. They weren't a locums or a traveling physician or PA or NP. And then the emergency department also had that increase from 60 to 95%. But on top of that, they reduced their ER staffing costs because they weren't paying anymore for locums physicians. And they had a a doubling of their average daily census. And these are the things that keep rural hospitals open. They are certainly at risk of closing, and some of their average daily census are very low. So having those kind of changes not only helps in the short term, but now one of our family practice residents who is training here in Sioux Falls just took a job at this area and will be there in July. So this was one of the reasons why he chose to take this job in the community, because he knew that he would have backup as a new physician. And then Airway, again, is such an important piece of what we do every day, and we want that to be successful. We do training in emergency airway courses, but also do that training on the fly so that people are more adept at doing airways, and it's even more important over the last 2 years with COVID. But you got to remember that a lot of people who are working in emergency departments in rural areas probably didn't have intubation as a large part of their training. And so getting them to feel proficient at this is really important. And then we do a lot of real-time learning as well. I had a PA, it was his very first day working in the emergency department in Minnesota this week. And he said, I think I'll probably call you a lot this weekend. And I said, I will be here. You can call me for anything. So we do a lot of teaching on the fly. I have talked a lot of people through their first time chest tube, or you name that kind of procedure. But we do it in a way that's very respectful and explaining it and facilitating learning that improves performance and instills confidence. And what I love to see are this new PA in 6 months to a year probably won't use us as much because all of the learning that happens. And so I think that is one of the things in medicine. We're all teachers and we're all learners and we're all continuing to learn. And I learn every day from the people that I collaborate with over the camera as well. And then we just want to make their lives easier. And I like this picture because, boy, it really shows what we've been through in the last couple of years. But if you work in a rural hospital, you probably don't have this many people that can attend to a very sick patient at 3 in the morning. It may be a provider and a couple of nurses. And I'll tell you another story that I had from Saturday night. A physician that I worked with many times. He is a board certified emergency physician, residency trained, used to work in Minneapolis for a long time before he came back to South Dakota, and was working in a small emergency department, and had a 3-week-old baby come in, has RSV, so has a respiratory infection. But the baby was born 6 weeks premature. So this baby hasn't really even made it to their due date. And so is a really tiny human and was having episodes where the baby was stopping breathing. So had to intubate that patient. And I was able to double check all of the medications. These are very, very small doses, and you want to make sure. So I was working with the nurse to make sure that was the exact right dose and in which order we would give all of the medications to prepare for that intubation or that airway, but also talking about, the airway checklist, and do you have everything you need, and what is your backup plan, and talking through all of those things to make sure that that airway was going to be successful. And he did an absolutely amazing job. And, even if you're working in a large pediatric emergency department, you are not intubating a lot of, 5 to 6 pound babies. You're just not. And so, those things are going to increase your adrenaline no matter what. And afterwards, he called to thank me for helping him. And I said, man, you looked cool as a cucumber. And he said, boy, I'm glad that you couldn't see my heart rate because I think it was 180. But he said, I really appreciate you helping me just to double check all of those meds because my mind really needed to be on how I was going to do this procedure. So being there and helping each other out is what we should be doing in healthcare, no matter where you are. So, and then this quote I like. These are some of my partners you can see in the picture here. But one of our CEOs said, I've got to admit, the 2 docs I've got on right now both have made the statement to me directly that if it wasn't for teleemergency, they would not have come out here because they were not comfortable with it. And we hear that all the time when I'm traveling. People will say, I'm just really thankful to have that phone a friend on the cases that I needed. So we are happy to be part of that story. And the future of telemedicine is bright, I think, as connectivity continues to be more and more accessible in all of our rural areas. More and more people are going to be working and living in rural areas, I think more than we have seen in, probably the last 40 or 50 years. People may be choosing to have their work from home job in a rural community. And so how can we help to support those communities in ways using technology and bringing the specialists right to them at the right time. So I think the future of telemedicine is bright. I think the future of rural areas and rural healthcare is bright as well. So I want to thank you all for giving me some time, and I will go ahead and turn this over to Dr. Summers. So I'm going to stop sharing my screen. Thank you.
Yeah, just real quick before Dr. Summers starts, if anybody has questions for Dr. Roan, you can start putting those into the chat, and maybe we'll answer them, or maybe we'll wait until the end after Dr. Summers gets a chance to talk and answer those questions. But do feel free to put them in the chat so you don't forget about them. Go ahead, Dr. Summers.
Well, thank you. Thank you for the opportunity to tell you about our experience, and many of the similar things that Kelly talked to you about. We'll reiterate, and I was happy to see that some of her numbers were almost exactly like ours. Made me feel confident that it's probably a kind of a standard way forward that we can think about in terms of that. We've been practicing teleemergency for a long time. Our teleemergency program is actually part of our larger National Telehealth Center of Excellence designated by HRSA, where we have 32 different specialties that practice some form of telemedicine, where teleemergency is just a part of that overall program. We began practicing telemedicine in the 1990s, and in 2003, out of some concerns that I'll talk to you about in just a second, we began teleemergency as part of our practice of that. I believe we were probably the first in the country to do this on a wide scale, and it started off as a grant, but quickly we needed to look for ways to sustain it, particularly because of its importance in a rural state like ours in Mississippi. In Mississippi in 2002, right on the cusp of when we began teleemergency, it was estimated that 20% of all Americans resided in rural areas, whereas only 9% of physicians practice in those areas. In fact, in Mississippi, 60% of Mississippians lived in a rural area, and 37% of Mississippians lived in medically underserved areas, which are really kind of physician deserts, as we can think about it. From that perspective, on average, it took 40 minutes for Mississippians in 53 of the 82 counties to drive to receive any kind of specialty care. And that includes emergency medicine specialty care. Even the hospitals that existed there were really almost Band-Aid stations in terms of what they could provide. And many were on the cusp of closing because one of the necessary criteria to be a critical access hospital was to have an open emergency department. And there just was not a dearth of physicians overall. You can see that Mississippi ranked last in the nation in per capita of physicians. That was a driving factor for us, Massachusetts being number one. And it was really a big challenge for us moving forward. These are rural hospital closures over the last 15 years. And I think that 2020, which is the yellow dots, show that this is not slowed down. It's probably going to continue and increase over time. The pressure again is to stay open and have access, particularly in the emergency department, even if you're able to provide regular hospital services. So in 2003, when we started, rural hospitals were again struggling greatly with staffing emergency departments, particularly if anybody had any kind of emergency medicine training, and being board certified emergency physicians were almost out of the question for most of these places. Most of them were staffing, and them were advanced practice providers, nurse practitioners. EDs were closing, and teleemergency was developed by us really to improve the quality of emergency care in these rural areas. I'd like to say this was all altruistic, but often those patients ended up being transferred to us as the only level 1 trauma center, only level 4 NICU, only transplant center, only everything in the state. And by the time we got these cases, a lot of times they were in such bad condition, there was not much we could do for them. Whereas if they'd had time-sensitive care on the emergency side of things, then maybe we could have better outcomes. So teleemergency, how did it develop? One of the things that we wanted to do when we started was we didn't want a second tier system. And that's very difficult, even today in emergency medicine, practicing through telemedicine, is to not provide a second tier kind of approach. We wanted to maintain the same standard as in-person care. And if the technology did not replicate the exam that you do in person, then the visit was not appropriate for telehealth. And that is a very high bar, even today, as we think about that. We often had to do, just like Dr. Roan said, train up our staff in those emergency departments, small rural emergency departments that don't see a lot of trauma or don't deliver babies on a regular basis or other things. We often brought the nurse practitioners in. We were only dedicated to the state of Mississippi as an academic medical center funded by the state. But so we were able to bring those in for in-house training in the academic center in a lot of cases, and still to this day, and require that any new site is going to have personnel that undergo our training program. As the National Center of Telehealth, we also are mandated by HRSA to study clinical outcomes and compare them to in-person visits. And we've done a number of publications since 2003 looking at that particular issue and comparing them to our own emergency department and outcomes in that kind of setting. Again, the teleemergency consult model is the same one that Dr. Roan talked about. We use a lot of carts that we roll around from room to room, because often these small emergency departments only have 2 or 3 rooms and don't have the resources to have more than 1 camera. So the flexibility of being able to roll a cart from room to room, and even sometimes to the floor of the hospital when they're trying to sustain someone after a cardiac arrest or whatever. These are teleemergency sites in Mississippi currently. We have 20 sites we do. Again, the way this functions mainly from a business perspective is through an economy of scale. If we, of course, had to put an emergency physician in each one of these sites on a continuing basis, that's not a sustainable business model. But whether we're billing insurance, which we can do now, or in the early days in 2003, we took a small fee per hour from each one of these hospitals. And while they could do that, they couldn't do that for having a board certified emergency physician in all these sites all the time. But the economy of scale of having 20 sites that had a small fee at each hour allowed us to have a dedicated physician to cover these sites. So this is one of our numerous publications about the impact of teleemergency on rural emergency care. I'm just going to go through some of our studies and point out some salient findings that I thought might be of interest to the group. We look primarily at a model of a multidisciplinary team, mainly of a nurse practitioner in these sites. Many of these sites only saw 10 patients a day, so it didn't make sense for them to even have a family practitioner to try to cover it, but a nurse practitioner has serviced them well. It cost effective staffing expense, 64 reduction in staffing cost in some places, though overall Dr. Rome's number of 25% is probably more on average of what we see. And the rural community benefits by 20% admissions locally that would have been shipped out otherwise. Similarly to Dr. Rome's experience, chest pain has been our main one. And we have had a lot of behavioral health things, though often we find that many of them getting transferred to our site. There's not a lot of behavioral health facilities in our state. And so many of them end up being transferred to our site for further care. So they have not been one of the top ontologies. They tend to get transferred earlier on. We have a lot of comorbidities in Mississippi. It leads the nation in hypertension, diabetes, heart disease, stroke, just about any disease state you can imagine, particularly up in the Delta where the rural situation is even more desperate. And so again, even like we see in our own primary emergency department, we see similar kinds of cases there in terms of acuity. In terms of the results, the one that I wanted to point out to you in this, comparing, of course, gender and race and other things that we do in terms of thinking about that, is the type of consult. We compared our telemedicine, teleemergency medicine consultation service to that we did prior to that as mainly a phone service. And we see a significant number of difference in the admissions and the death rates and other types of indicators, transfers and AMA for those consultations. And I think that's a very important point. Many states, even including ours, have legislative debates of whether or not phone service is going to be equal to video service. And we're very firm believers that video service from our data is an important aspect of this teleemergency service. Again, 25% reduction in rural emergency staffing cost overall, similar to Dr. Rome's, 20% reduction in necessary transfers. And we are, of course, focused on whether or not we have the same outcomes that are on par of those of our academic medical centers. So a lot of our studies are focused around that in our publication. Our satisfaction rate, 98% of patients think they get good overall excellent care. I think that's important as they look to the camera and see that there's somebody from the medical center, which is our only academic medical center in the state, is also in the room with them. 99% of the patients said they would likely come back and use that system again. And 97% of patients were comfortable with this type of care. Talking about outcomes, and you can't get a harder outcome of whether or not you survive cardiac arrest. And we compared our own in-house at our level 1 trauma center survivability to that of our teleemergency rural emergency department sites in a publication that we did a number of years ago. And on initiation of teleemergency, the survival rate in those teleemergency sites was abysmal. We're approaching that of what you could get if you came into our own emergency department. Remember, I told you that our standard is that you should have on par outcomes as you do at the large urban centers, and we're approaching that. And currently, there's not a statistical significant difference in those outcomes, which we're proud of. One big thing that I know, actually, I'm going tomorrow to Washington, D.C. to testify in front of a congressional panel with regard to telehealth costs, particularly during the pandemic. But that's one of the big things that the Congressional Budget Office wants to know is how much is this costing us? Is it more than we would see if we didn't have telemedicine? And particularly teleemergency is one. We recently published just this year an article on do hospitals providing telehealth and emergency department have lower emergency department costs, a very objective and rigorous analysis with a number of biostatisticians and almost about 15 years of experience in doing this and data over that time period. You can see over this time period that even from the beginning, the non-teleemergency sites in Mississippi had much higher costs than those that were utilizing teleemergency services. And this has continued on to today. Costs in general are going up, as you can see, as we track that. But even in 2017, which was the latest Medicare data that we could acquire to do this analysis, is still lower than it was 10 years ago in emergency departments around there. So this is one of the things that our Congressional Budget Office is looking at, they're very interested in, want to know, are we reducing cost overall? More recently, we've actually gotten a grant from HRSA to look at what we're thinking about in terms of layering services on our teleemergency backbone. Just as these small emergency departments and hospitals don't have a board certified emergency physician, they don't have psychiatrists, they don't have OBGYN, they don't have toxicologists, they don't have a telestroke. That's how telestroke came about. They didn't have neurologists. However, to develop separate pipelines for each one of those specialty services into those hospitals is a very costly operation. In fact, when we tried to do it for telestroke, creating a separate pipeline and system and all those things was not cost effective. And in fact, many of these rural hospitals needed the same kind of triage operations you do when you walk into your academic medical center emergency department, where you're saying, all I know is I feel funny, or I'm weak and dizzy, or I have a vague kind of shortness of breath or chest pain. You need someone there to triage them, to sort it out, to differentiate the disease. And that's what emergency physicians do best, is differentiate acute disease and then layer the service on top of that. Whether it's telestroke, telepsychiatry, and those are our focus on our TNGP grant with HRSA right now is looking at this layering process. How does it work? Just like we would consult a psychiatrist in our own emergency department, we have a room in which they consult a psychiatry consult can be attained by all our 20 network teleemergency sites. We're working on that process now. We've been doing it for a couple of years now, but now formalizing it in a more rigorous process and looking at that. For a state like ours, which leads the country in strokes, and having the rurality and the disparities associated with it, this is an extremely important process to work forward. Our challenges, of course, Mississippi ranks 49th nationally in connectivity. More than 30% of residents lack access to capable service provider. I was in one of our rural hospitals recently, walked through the emergency department, was packed in the waiting room. And I walked in the back and there was only 2 patients. And I said, why is your waiting room packed? There's only 2 people in the back. They said, oh, those are just people that come from the local community here that come into the waiting room in the emergency department so they could access the free Wi-Fi. And so that was a real big issue, connectivity. Medicaid, of course, and Medicare are debating on how much coverage they're going to do moving forward, even local states. Medicare, 75% codes are reimbursed in Mississippi for telehealth. Mississippi third-party insurance and Medicaid. We've been fighting for parity reimbursement in a lot of cases using a modifier and different methodologies, which will be a continuing battle. And post-pandemic, I think we're going to see some changes in that nationally. Lastly, I wanted to tell you that as funded by HRSA, we've recently developed a TeleEmergency Cookbook. It's a resource manual for developing teleemergency systems. A lot of healthcare systems are looking to develop their own teleemergency systems. And we have a step-by-step cookbook of the way we've done it. It gives you charts and flow charts and graphs and methodologies and technology things that we found that have worked. We're going to be hopefully publishing this through ACEP soon. but it'll be something that can be purchased and bought by any teleemergency system or hospital looking to develop a teleemergency system. And that's all I want to talk about today.
Thank you, Dr. Summers. Anybody have questions for Dr. Summers or Dr. Roan? I would encourage you to unmute your line and go ahead and ask your question. Carl, I see in the chat you asked for a link to the cookbook. I think Dr. Summers just said it isn't published yet, but it will be available for a fee through ASAP.
Yes,
Okay.
in fact, we just finished it 2 days ago, so you're seeing it hot off the press. Because HRSA was funding it, we're going to talk to them about how to disseminate it. I'm sure that they want to give widespread dissemination. We're not going to be making any money on it. We're just doing it at cost, but we want to hard bind it and make it something available.
Sure. As soon as I saw that, I was like, what? I didn't know about this resource. So I was excited about that. So if you do find out that you're going to be disseminating it a different way, I would be very interested in being able to share that with this group.
Okay.
Yeah. Anybody else have questions for our doctors today? Okay, so hearing none, if you have them, go ahead and drop them in the chat. Otherwise, I have just a couple of things. One, I wanted to just talk really quick. Thank you, Kiona, for putting up the post-polling questions. You guys can go ahead and answer those while I talk here. There is a question in the chat about bandwidth issues and overcoming those. If you guys wouldn't mind maybe answering those, if you have a suggestion, any kind of response.
Well, bandwidth issues are a continuing challenge to us. We've gotten some FCC grants recently. The pandemic created a new urgency, of course, for most rural areas, and we're trying to engage with that, but it continues to be an issue. Many of, years ago, a lot of the school systems, public school systems, developed pipelines for bandwidth, and we've kind of leveraged some of that in our state to allow some of these small rural hospitals to utilize those connections too. And that's been a great help through that. I think we're going to see more of an issue when we look at things like remote patient monitoring and telemedicine, things like that.
And I think I would just say, because we use fiber in our ER, we use Wi-Fi for a lot of our other programs, but we have had some challenges when we went live in Red Lodge, Montana. It took us a year to get the fiber around the mountain to get down into Red Lodge. And so, but we work with local areas and local providers of connectivity to try to make sure that we're getting that connectivity into the hospitals as well. Certainly if they already have the connectivity to the hospital, it's a lot more helpful, but boy, I mean, a lot of very rural hospitals don't have that. And so we've really worked at it, and we're currently doing some kind of testing on the Starlink pieces to see if that is going to be a little bit more reliable source that's not fiber, so that we can use it with our program as well.
Thanks. Steve Barnett, I saw you had your hand up. Go ahead.
Yeah, thank you, Nicole. I appreciate it. I wonder, and this may have been covered, and I apologize if I'm asking a question that you did cover. As you know, we often find ourselves multitasking. So have you had trouble contracting with specialists that you want to bring in, or are you managing that well?
Well, in our experience, again, that layering process that I talked about has been important. And if we, of course, can turn that into a billable service, and also integrating it into their regular practice. Like I said, we have a teleemergency room in our own academic medical center emergency department. So for them, it's just another consult within our own emergency department, and not something that's outside of their routine practice. And so again, the billing issue is a big issue. Unfortunately, in our state, about 50% of our patients are either self-pay or Medicaid. So it's not it's not the thing that's going to break the bank on us, but that's kind of the way we've addressed it.
Yeah, we've found it challenging sometimes to get the subspecialists that are independent. Typically, they may be coming through a health system to us, but it's just sometimes challenging to get them on board with telemedicine.
I agree. Sometimes it is.
I think COVID has certainly been helpful for that when everybody was forced into doing telemedicine and then realized it worked.
Yeah.
So I would say I spent like 10 years talking to specialists about how this could work. And then, it only took a global pandemic to get them to try it. So I think that actually was really helpful. And, we work with, up until 30 days ago, we were Avera eCare and now Avel eCare. And so our health system that we work with here locally does do a lot of teleconsults, but man, I think that COVID really brought us to get all those specialists on board.
Thank God for COVID.
Yeah, right.
Okay, we are out of time. I see there's one more question in the chat about kind of getting the academic medical centers on board. So Renee and Dr. Summers, if it's okay, I will connect the two of you. So Renee can maybe pick your brain a little bit about that. And Dr. Roan, I don't know if you have any thoughts on that. I can connect her to both of you so she can continue to have that conversation with you. One of our learning objectives was to learn about related resources. And I know Dr. Summers mentioned one that might be publicly available or available for what I'm guessing will be a small fee. The other thing I would always refer you all to is the telehealth resource centers. And I have reached out to them to find out what they have on this topic, and we'll share that with you when we share the recording with you. So that is really all we have time for today. So thank you, Dr. Roan and Dr. Summers, so much for agreeing to do this fantastic information. I appreciate you all so much. And everybody else, have a good day. Thank you.
Thank you.